and you, itself, and all the executive members, very much be here. So, what I'm going to speak about is how to choose the proper lubricating for a dry eye patients, and why this is important. Although there are no data from India, you'll be surprised to know in USA the market value of this lubricating drop per year is this much. Okay, towards it thousands of crores. This is the amount of money that is the spread, bought, and involved in this dry end market. That's why this is a very important topic. And you must have noted, all of have noted this. Every 6 months, one company comes on with a new drug. Right. This is the magical drop that you're looking for. Within the 6 months, another magical drop becomes it. So why? Because we have to accept this fact. We don't have that capability at this point of time to discuss the normal TFL. What we're trying to do is, as far as possible, you increase the TFN that we not damage the outer surface. I think both the initial skiller they have already given a brief outline of how dry eye adapts the surface. Also, tear substitute, these are always the first line matrix. And if you properly choose the tear artificial tear or care supplement, most of the cases of TDUP dry eye can be managed. Okay. So, these are nothing but the applied solutions consisting of different buffer. If you show this figure, this dibbles and hydrogens, these are the main constituent of any artificial care, right? So the other jets like jelly digit, oil, buffer, ions, preservatives, these are additional to that. So the main component is by is dibbles and hydrogen. So there are at present we have what is a demoset basically? Since this is the main component, we all have this toffee when we were kids. So what does it do? It forms a slightly layer of coating over the top. Similarly, demoset each and PC is all this case product that coats the ocular surface. So that is the primary purpose, right? The second important property of early lubricant that you should be aware of is humectant. So what does a humectant do? Humectant is depressant plus some hygroscopic property or it absorbs water. So if you just be depressant, whatever type for which it is there, that will be there to protect the surface. If you add some humectant, depressant the ectopic plus will keep on absorbing water. So the retention type it teaches. These are the two different property tests of which you can classify the correct available accuracy tiers, right? So CMC primarily it has your demonstrate properties. We could arrest on the surface. If you go for SPFC, hydroxy propane potential curves, it has demonstrate plus some monetary property. Then move on to the third generation, which is polypropylic glycol or polyvinyl alcohol or SPGOR or glycerin. They all have demonstrate immediate property plus they have some extra properties like lipid discharge. Last is sodium value. Okay? Now let's post the proceed this but see, yes, it has certain advantage over CHC. That includes it promotes corneal epithelial migration and proliferation. Sodium hyaluronate is a natural component of the collagen, THO, whatever biological tissue, right? So this steps in proliferation, migration of epithelial cells. So this basic both categories is must be aware of so that it can choose the perfect lubricating drop when you are setting to open. So now, other than that, these are the analytics that is being included. Osteoprotectants, as the first speaker highlighted, eye fluid osmolarity leads to a dangerous phenomena, which is the prognosis and autophagy. Apoptosis, we all know from the basics better. Okay? It's a programmed cell death. The moment your ocular surface recognizes that this epithelial cells under damage, it is start with its own epithelial cells, right? So that is the complete pathophysiology of early ocular surface damage in dry eye. So there are different molecules like L-carnitine, erythritol, betaine, sorbitol, glycidine, and trehalose. All these they have osmoprotecting properties. So if you feel your patient is having dry eye with some surface damage, then it's better to choose a preparation which has all this component or any of this component in the lubricating. Right? Second important is antioxidants. Nowadays, there are few, if you open your social media, you can see there are few proponent of vitamin D pick the basic cause of all pathology. Although that is not true. Few physicians and researchers, they are propagating vitamin D, topical vitamin D, it is soluble dry eye. Although at आपके क्षेत्र about if you practice with they use vitamin D. But antioxidant that it is vitamin E, white futin, likewise. If these are there, that is going to reduce the oxidative damage to the ocular surface. Now, if you remember the chart, the pathogenesis chart which my previous research showed, oxidative damage is also an important component of ocular surface damage in dry eye. So, if you feel your patient is having a dry eye and it's a bit severe enough, it's good to choose something which has early of this component, right? But with a caution when we are using vitamin A based professor. Because if you go to a dermatologist for management of acne, they didn't give you retinol acid. Why? Because vitamin A prevents sebaceous gland secretion and LEG. And you know, Bevopet gland, you can codify sebaceous gland. So if you use vitamin A based combination, there is a theoretical risk. It may reduce your sebaceous secretion from the Bevopet gland or liquid secretions from the Bevopet gland. So there is a theoretical disadvantage. It may further induce injury rather than treating the dry eye. So while using vitamin A test population, you should be a little bit more cautious. But vitamin E कोई tension in like I said, whenever you expect there is certain plus or damage, it's always good to have some duplicated with this component. Now, oily agents like castor cheese, flaxseed, or even mineral oils, all these are useful when the patient is heavy. They will match large description. With that is it is going to replace the lipid layer. Nowadays, with more and more research, rather than this simple oily agents, people are cook up with liposomes and oily type of droplets. Those are useful. It is more soothing to the surface. And here, one of the little bit more theory, you know, the lipid layer of human cornea is basically consists of two types of liquids, non-polar and polar liquids. So there is a hypothesis. If you go in one of the article published in Invest IUHS, you will find that these polar lipids, they may have a low diametric ocular surface. So LE present that contains polar lipids, right? So there that is helpful in reducing damage. But this is only under research. Artificial with Yopta very property coming up with a polar liquid formulation. Just to update you for someone else. So now osmolarity electrolytes. So electrolytes are there here lubricating drops to alter the pH. So that has to be with a certain range that would not damage the ocular surface. Okay. And also it will take care of the hyperosmolarity part. So normally bicarbonate potassium are there in almost all the populations. However, if you find any lubricant is raw but it is patient, it has both cationic emulsion, it's better to go for those population. Why? Because cationic emulsion, they are positively charged and your glycocalysis is negatively charged. So they interact, they attach each other. Okay. And the retection type is more and the ocular surface healing is better. So if any company comes to you and say that we have cationic anions in a EPS formulation or deer population, then prefer that. Preservatives, whose commodity is better permit chloride, you won't know that. So they prolong the shelf life. It's not that they are bad only. And you know, you must be getting patients, they are coming from very far and then they come back again up same month. So in those patients, it's not that bad habit to eat preservative drugs with preservatives. However, one thing you should always remember, where to go for preservative-free drugs. Whenever the frequency of draws is more than 4 times, always prefer a preservative-free topical drugs. Because if it goes over 4 times, this better to write paradoxically stop damaging the ocular surface. Okay. And in India, I think very rarely there are drops that are absolutely preservative-free. So the alternative is soft preservatives. Okay. Soft preservatives, you put gel up, purite or polyglot. Okay. So what they do, the moment they come in contact with ocular surface, they are modified in some non-toxic forms. So the theoretical risk of damage to the ocular surface is not there. So you can't, if your patient cannot afford preservative-free medication, you can go with some drop to the soft preservatives. So when this brief about all the component, I come to this classification. This is a classification given by Barabido Ita. This classification is important if you want to use this at this because there are a lot of classification, right? So, but that is very difficult to remember and practice your day-to-day clinics. So this classification helps you at deciding which to go for in your day-to-day practice. Basically, they are categorized your lubricating drops into three categories. One is wetting agents or lubricating agents. Wetting agents means they sole purpose is just to lubricate the ocular surface, like 0.5% CMC, right? The second area to see this blue bar, these are the multiple accent tier substitutes. They note they do have this deposit like CFC, HGMC. In addition to that, they have something else. Okay. So that is going to increase their duration of except or sub epithelial cell protection. All these things that will help. Okay. So among this comes your drugs, those have polyagents or those which have some electrolytes, viscosity, SF, NS, all these come under this multiple accent pair substitutes. The last part is important, which in your ocular surface modulators. So remember, admitted only drugs which has antioxidants or oscoprotectants or agents such as cationic emulsions that promotes your epithelial healing are considered as ocular surface modulators. Okay, so you can classify your drugs into these three categories: vertigated CLC, SPMC, multiple action CMC, SPMC, sodium hyaluronic plus AB electrolyte, maybe coenzyme Q, bacuitrihapus, anything like that. Third is ocular surface modulator, which primarily is trehalose based or vitamin E coenzyme Q based or cationic emulsion based. So these three broad categories should have in your mind. How this will be help you? Because suppose you have a patient like most cataract surgery, it's ocular surface FCP pike, the patient says कि कुछ तो चुभ रहा है. This is very common. In those cases, simply prescribe a vertic. Okay. Suppose a patient you are examining, but the sites are there. For example, dryness symptom is there, but when you do Selmar, it is less. When you still, there are few spots. In those cases, prefer multiple acting agents. If you feel it is a lipid deficiency, then use some method oil or some lipid lipo of formulation. If you feel it's primarily the basal is deficit, so T2 stability is not there, then use something that will go to supplement. Okay. So those are multiple acting substitutes. Then third is ocular surface modulator. Suppose your patient is in severe dry eye, cicatrices is there, filaments are there, multiple SPKs are there, and you are stealing the conjunctiva is getting stay. So all these are suggestive of not only the dry eye is there, it has also a component of ocular surface damage. In such cases, you have to go for some formulation which has all these agents which I just highlighted. Okay. So in addition to this is only about lubricating drop, right? The third group of patients with ocular surface damage, when previous quicker diet, please check for the root cause. You have put it the fault. The patient may have pneumonia arthritis, maybe Sjogren, or maybe a case of SS. Right. Can practice? Is it possible for us to practice what Big Four suggests? So absolute no. Europe is busy. You are seeing cardiac patient of dry eye comes to you, it cannot follow the Big Four criteria. Okay. For that, we have to have a dry eye clinic and we have a dedicated research staff who we do static of osmolality through all these steps. But all of us know in OPD, a dry eye patient comes, hardly do a TPOP or a submo. Beyond that, most of us do to anything else. So this is a classification at RP Center what we have proposed for day-to-day practice. It's not for cornea research specialist or cornea specialist. It's for a practitioner. Practitioner is sitting in OPD or by resident is sitting in OPD. At RP Center, one OPD patient will be around 100 patient will come to your OPD. So you cannot sit and just classify Raya flat. Okay. So but those practitioners who don't have investigative tools or don't have the time. So this is simple classical system you can follow. And if your patient is not responding, you should always refer to suffering with pain in Raya and riots. So level one, patient will have only symptoms. You do edit test, all the tests will be normal. But the patient case or telling, yes, I had something for it, body senses and some periods. So in those cases, wetting agents are good enough. Plague CMC extent is good enough. Sodium hyaluronate, if you give, that may be useful. But unnecessarily increase the cost. The cost of the drug is much higher compared to 0.5 CUC. Level 2, symptoms are there. In addition, some basic tests that you do in your OPD, those are positive. Theum meliscus tide maybe less than 0.5. TU kinelin less than 9. Subamine less than 10. In some patient, there is a problem. Okay, and that problem maybe not that severe, but the problem has started because of this dry eye. It may be some hyperoscularity that is then the ocular surface. So in such patients, in Dynasandui or CFC or SPFC, you have to use something else. Okay, in this species, pseudocalinum is probably the best option because it has bacterial properties also. A very level 3 is you have both symptoms, both about the abnormal clinical test. In addition to that, your switch filings are there which are having to be yes, not only the dry eye component is there, but it has started damaging the ocular surface. Okay, right? Maybe there be multiple SPKs or the catheter is taking state. In all these cases, not only lubricating drops, but you have to use ocular surface modulators plus immunomodulators because once the ocular surface damage has started, you have to use anti-inflammatory drugs because you know in this level 1 and 2, the primary problem is here is not adequate. When you reach level 3, the primary problem is the invasion that is going on the ocular surface. The region is okay, but the primary pathogenesis here that is happening here inflammation. So your immunomodulator flatum must be level 3. Then level 4, all these are present in active. In addition to that, there are telltale signs of advanced ocular surface damage like corneal softening, superficial keratinization, dermatization, cornea melting. All this is your patient has a very advanced form of dry eye disease. And always remember such level 4 patients, the underlying cause has to be added. Cases that would never occur without underlying cause. All this cause has already been accumulated. And in this patient, the immunomodulator has to be very strong. Unless the patient with the steroid ill problem patient, you have to start with steroid and that to produce or frostbite or produce an estate to 1%. Slowly produce which allows they will be effective in level 3 only. They won't be that much useful in this level 4. So this is a broad guideline how you should approach in your when you are dealing with the patients of dry eye. The community class active we have a case discussion. I will just say few of my cases recently and just to update here at the center you know, for lipidic there are basically 3 trial. I hope this rules cover that. Opus what 3. So in all the trial if you summarize, there is definitely improvement in the cell depths. But some of the science part doesn't improve in this trials. And the exact cause may be related to the case selection. They included only idiopathic cases of dry eye, where the symptoms, the signs were not that significantly worse, which could have been taken care by simple lubricant. Okay, so nicotic gas came up to have no significant impact of size of dry eye. So what we are doing here, we are planning a multi-setted trial to look into this aspect. Lipidic gas definitely it's one in symptoms of dry eye. How it is useful in trial with other associated acnocarditis. For example, I had big cases of rheumatoid arthritis with dry eye. The patient were on cyclosporine, but the ocular surface was congested. Each night the patient used to put cyclosporine, they used to get a sticky cases and all these things. So we shifted those patient to lipidic gas and till now into night gets lipidic gas, patient is still on. So patient is better. It's not that everything has gone, inflammation has been controlled, but the patient is much better than with cyclosporine. And so the patient's acceptance is even better with refractive glass compared to cyclosporine, although the patient's number is too less. It may be subjective us. The moment we complete the trial, then we may be able to keep better kappa. The second cases are filamentary keratitis. It's routine cases filamentary keratitis, you have put steroid and estrogen. But I had a patient, this patient, see, the moment I used to taper steroid and put her on cyclosporine, the filaments taper wake up, right? And we did evaluate recovery from rheumatology, but there was no specific cause. So that patient is symptomable lipidic gas, of course, with steroids and then taper it off to lipidic gas. that patient is still pickle-and-spray for last 3 months. So this is the third case that adds up a good outcome with the grass. And VKC is steroid-reduced glaucoma. So in my unit, I pick up for Kwame and Dr. Tanuj Dada is there. He's looking after glaucoma. And steroid-induced glaucoma in PKC patient is a deep challenge. Right? We see a lot of patients only absolutely clear, VKC perfectly controlled. There is total optic atrophy. Why? Because patient kept on putting steroids. And BKC patient, remember, didn't do have dry eye component also when the disease is adverse. So what we have found with steroid-based glaucoma patients are there with BKC, weak ocular surface proper. We have started using this lymphatic RAS. Till now we have 2 cases who have completed 6 weeks color. I'm not discussing any patient with 2 weeks or 3 days color. But if you go to the trials of lymphatic RAS, you have to wait for 84 days to have some significant impact of lichtigas on the ocular surface. So, in 6 weeks, the inflammation is manageable. Again, it's not absolutely free of inflammation, but it's manageable by the patient. So, liquid glass is usable. Is the indication and everything. It's still not absolutely clear to us. At present, idiopathic dry eye is definitely useful in relieving the patient's symptoms. I feel it's the patient's acceptance is better with liquid glass compared to cyclosporine. But if you follow the ITO study where multicentric the trial was in India, they found that cyclosporine and liquid have equal effect. Patient's tolerance may be better, but if all the study, it has been found the patient tolerance is as good as cyclosporine. So the decision is with you. If you feel any patient where you don't want to use cyclosporine as a immunomodulator, then liquid grass is the drug to go for. With this, I'll upload here. Thank you so much. Thank you, sir. Right, first, actually, last time, please come at the podium. Prafulla, you said that you should pick in all your cases on cyclosporine to limit the.
The 4 weeks. So, what was the reason for you to shift from cyclosporine to lipidem? I mean,
As I said, patients are not against cyclosporine. Each time they used to put, they had 80% burning on this.
was the brand changed? It was oil-based cyclosporine or what?
So if you see the percent, I will not take any company's name.
No, but
If
so
you
I will
will
say
say
it was
0.09%.
Okay.
So 0.09% is this nanotesla based, and 0.1% is again from one company, but that is your lipid based formulation. But we prefer 0.1 when the inflammation is severe. Because I believe 0.09, 0.1 is better for stopping anti-inflammatory effect. So both the patient, but as I said, it's not that if you keep 0.09%, 100 out of 100 will have symptoms. 20% will be there out of 100 who will be intolerable to that drug. So those groups we include this lipidograph because lipidograph is a new drug, right? Most of these patients they already have putting cyclosporine since a long time. The moment we shifted, that irritation, burning, all this have come down. So the patient acceptance is better in selected group of patients, not in all patients. So don't shift all your cyclosporine patient to lipidograph.
Any side effects for this lipidograph?
Lipidograph again you have to follow the same instruction as cyclosporine. You have to apply pressure of your puncta because if the patient it goes into your nose and then your pharynx, they do have this.
How safe is this lipidograph?
How safe I cannot tell you. As I said, I have used it for 6 to 8 weeks maximum for dog. But so far, we haven't seen any significant side effect other than mild irritation, which is better than cyclosporine. If you go for
So I
this,
thought gave just decongestants and non-steroidal anti-inflammatory drugs.
decongestant
So
dry
the inflammation.
decongestant and dry eye, they contain antihistaminics. Never use decongestants because they will be beneficial in short term. The moment the patient gives this for 1 month, the dry eye everything goes up because you need vessels, you need anti-inflammatory cells to come. So decongestants are not a solution for cyclosporine reduce irritation.
Non-steroidal anti-inflammatory drugs.
And I said, as a cornea surgeon, we avoid that because there are clear-cut available reports. If your ocular surface is damaged and you use NSAID paradoxically lead to your more NSAID even there are reports of cornea melting post NSAID. So NSAID we clearly avoid, and I never use NSAID for my cornea case.
Prafulla, given a choice, you have tackled university or cyclosporine. this new molecule?
Tacrolimus, I'll tell you, tacrolimus we don't use for dry eye per se, but it is very effective in allergic dermatitis and dry eye. We have a paper published and I'm going to show you where we found that all this PKC patient who comes with severe ocular surface damage, if you use combined immunomodulator like tacrolimus plus cyclosporine or tacrolimus with lipotegrast, it works wonder. And tacrolimus, when you are using, you have to be a little bit cautious. In 2008, there is a red alert by FDA because all the patients for leukoplakia through pre-malignant state were given tacrolimus, and there was high incidence of malignant transformation. So FDA come out with the red alert in 2008. Don't use tacrolimus for a long time. Those patients were taking tacrolimus for more than 6 months. So personally, I feel if you are using tacrolimus, use BD dose for 1 month, OD dose for 1 month, once alternated for 3 months. Don't use beyond 3 months because tacrolimus can damage your ocular surface in long run.
We said in case you prepare the lipotegrast over the cyclist.
No. Those two cases were PKC with steroid-induced glaucoma and dry eye. So in those patients, steroid couldn't have been given. We gave cyclosporine, but that was not working, or the patient was not tolerant to that. So in those group of patients, we used lipotegrast, and 2 cases they had favorable outcome.
So when he do cyclosporine, it generally start with steroid because it takes 1 month for the action of cyclosporine to pump. So the lipotegrast also takes 2 weeks.
Yes.
So do they start with steroids and that check and big lipotegrast, or you directly keep them on the.
So as I said, I'm showing 3 levels, right? So when it comes to level 3, there you have to use immunomodulators, right? But level 3 is you have symptoms, few sites positive and few surface damage. In those group of patients, you can skip use of steroid. Okay, or you can get away with mild steroid like 0.5% lodipretinol or 0.5% fluorouracil. But for level 4, where filaments, synechiae, cephalopolyp is there, you have to use steroid. Lipotegrast, cyclosporine are not going to give you relief from that symptom. So it's a good practice to start steroid symptom to cyclosporine. But if the dryness is not that severe, simple cyclosporine or lipotegrast can also be given. Even this opposed trial, they use lipotegrast only, they didn't use steroid together. So you can give in mild to moderate cases only immunomodulator. Steroid has to be given in severe cases.
What about using combination of lipotegrast and cyclosporine?
There is one study in Japan. I think we should wait for the result. See, cyclosporine acts on calcineurin inhibitors, right? So calcineurin inhibitors is T cell action. What lipotegrast does, it inhibits T cell activation around. So if you have already inactivated T cells, then there is no point of blocking its action because T cells are not there to act at all. Okay, so that is the size. But the study, what they are aiming is they are comparing combination with single. The hypothesis for that study is what I feel. So when you keep lipotegrast, suppose there are 100 lymphocytes, is no drug can block all the 100 lymphocytes. It will block say 70. So less 30 lymphocytes are still getting activated. So if you give a cyclosporine also, then it will block the binding of those T lymphocytes to the calcineurin inhibitors, right? Calcineurin. So you are blocking both the steps. First you want to stop the activation completely. If lipotegrast fails, then next step will be taken care by cyclosporine. So that is the rationale for the study. But again, you see all this dry eye patient you did a very huge sample. Based on 6, 10 or 50 cases, no recommendation can be given. So let's wait for that study. That study may give us a better idea whether it could combine or not.
What's your approach for the neurological dry eye? But there to have an acute dry eye and that it continues for years together. So how do you start and how do you continue?
If I got the point, I think you were asking somebody is having systemic immune disease, autoimmune disease with dry eye. So remember all these patients with systemic immune disease and dry eye, lipotegrast, cyclosporine, they have no role in treating the cause. They are effective only once you control the systemic inflammation. So use either like nowadays we are using microneedle morphetin is quite good in controlling all these systemic immune diseases, or azathioprine, okay, or any recommended drug in consultation with rheumatologist. Now, once the systemic part is taken care of, and for that, CRP is a very good marker, although very rarely we use it. If the patient is having systemic immune disease, check for CRP. If CRP is high, dryness will be more. So keep on checking the CRP and ESR. Once the systemic part is taken care of, CRP and ESR in control level, then your steroid can take care of that dry eye part. Once steroid has taken care of the acute part, systemic disease control, acute inflammation control, then comes the role of your cyclosporine or lipidic graph. So in the treatment arm, first you have to use systemic immunomodulator. Second, you have to use topical steroid. Once the disease activity has been brought down to a significant level, then this drug will have some maintaining activity. But they have very minimal role in treating such cases.
The last question is how do you manage your persistent and liver severe dry?
Severe dry eye lesion, again, as I said, if it is associated with cicatricial causes, patient developing SS, OCT, M3, use ELG or use any cord serum, Autolux blood serum, because they have some growth factor that will help you. In lubricating drop, use sodium hydrogenate 0.1% or use CLC 1%, not 0.5%, along with trehalose. Okay, a lot of fellows from Narayan Netralaya are here. You all must be fan of trehalose. Okay, so trehalose is useful in such patients. Okay, so trehalose based lubricating drop and ALG or something with growth factor. Those are useful. Immunomodulator, all these things are useful only after the initial part is taken care of.
What's the role of insulin drops for this first?
Insulin drop, okay, so if anybody is a fan of insulin eye drop, I'll beg your pardon. For me, it's a useless drop because you see, there has to be rational, right? Insulin has some growth factor, like insulin growth factor 1 and some liver growth factor 2 growth factor, hepatocyte growth factor, sorry. Now, AMG has both this growth factor, along with that, another 18 growth factors. Okay. Autolux blood serum, both these growth factors is there, along with some other growth factors. So, insulin-like growth, insulin, topical insulin is indication is not that broad, I would say. But yes, it is useful if you are dealing with some cases like dry eye symptom signs are there, some epithelial damage is there, and some conjunctival damage is there. In those group of patients, it will be helpful. But patient with clear-cut ocular surface damage, I don't think insulin eye drops are going to help.
Any role of dopamine?
Dopamine. Okay, we have a tried dopamine, but can you just elaborate in what perspectives that you are saying?
Like in Parkinson's,
Okay, this is very, I would say there is one research group which are actively looking at dopamine and nitric oxide inhibitors, but that research is still going on. We don't have many data on that. Dopamine per se, the dopamine URO is the like any growth factor, we divide it into happy and bad. So dopamine is the happy growth factor. It makes you happy, it makes you feel good, it controls them life here. So it acts on the neurosensory channel. Yeah. So neurosensory factors are nowadays, dry eye is earlier it used to consider as a local factor or something like that. Nowadays everybody accepts it's a neurosensory abnormality. So dopamine can be useful by acting in that pathway, neurosensory pathway. But how, what frequency, what formulation, systemic, topical, it's a big, huge task. We need multiple studies, multiple research to come.
Any subset of patients in which you would prefer the lefty-grass over cyclos?
As I said, till now, cyclosporin was always there, right? So most of the dry eye patient, if we are not responding to cyclosporin, we have shifted and we have found its useful in few groups. But we have started a trial, multicentric trial. Here we are looking into use of lefty-grass, not only idiopathic dry eye, but dry eye as a higher. Because we see a lot of allergic conjunctivitis patients with dry eye. We see a lot of systemic patients with SJS, Zobril, OCP with triad. So we are exploring the use of this drug in these cases as a maintenance therapy, not primary treatment therapy. So I cannot say whether they will be useful or not.
So is Liftigras useful in patients with evaporative dry eye? And vitiligo?
Evaporative dry eye, this is a Lifanda sponsored program, I don't say yes. But if you ask me personally, why would I go for Liftigras in evaporative dry eye? Again, go back to the basics. Suppose it's a level 1 evaporative dry eye, no need. But evaporative dry is there, patient is not using any drugs for 1 year. Then evaporation lead to hyperosmolarity, leads to epithelial damage. Epithelial damage will induce inflammation. So if you are thinking that yes, inflammation is formed, then Liftigras should be used. If you feel no, it's a simple evaporative dry eye, no need for going for Liftigras.
With the clinical side that can be start by SPT on the surface. That is the technical part.
There are certain clinical signs doctor ignore. Whenever you suspect inflammation is there, Liftigras, cyclosporine, age maintenance therapy, acute therapy is by steroid only. There is no alternative to steroid.
So what are your primary indication for Liftigras? It is confidence.
Primary indication for Liftigras, okay. So as I said you know, whenever there is a surface damage, I start with some steroid. If the damage is severe, I start with elon or predacetate. If it is less, I start with lopridinol or chloromethylone. I continue steroid for 2 weeks or 3 weeks depending on how the patient is responding. But by rule, I stop steroid before 4 weeks, okay. So by 4 weeks, I stop the steroid. Then I continue with either Liftigras or cyclosporine. Now we are checking in our study, we have a cyclosporine arm, we have a lubricating arm, we have a Liftigras arm. So the study, once we complete maybe in 1 or 2 years, then we'll get a clearer idea whether cyclosporine or Liftigras are same or is there any difference.
Prafulla, one more thing I wanted to ask you. 2 questions. You talk about topical steroids. Lot of steroid abuse is there in our country. And do you advise only smart steroid to be started when you get a KKC or a triad patient, or do you advise a stronger steroid like Vedasi? Number 1. Number 2, you spoke about 3 idols. What is the article which is published of 3 idols is 3%. But there are a lot of lubricating drops which are mentioning 3 idols, but the concentration is not mentioned. So now there's like a cocktail, you add everything. So they added 3 idols with other ionic buffers or electrolytes and everything. So does that 3 idols in that cocktail eye drop lubricating drop really helps, or we should concentrate on 3% 3 idols?
So trehalose, you know, the research article, all these are experimental or mice models. They will find useful. But you know, when you're dealing with a patient, right, and you have one option with trehalose or the less percentage, one option without trehalose. So the logic says ki why not go for trehalose, right? It may have some impact. And the second question that you like, whether we should go for that, it's like if you don't have 3% ability, why not go for 0.03? So that will add something, okay? And what Sir said, it's a big problem. You know, nowadays, don't take my word negatively as a not all people. What companies are doing, they are not focusing on the physiology of the TFL, right? So what they are doing, they are taking CLC, so potassium डालो, bicarbonate डालो, trehalose डालो, थोड़ा कोइनियम Q डालो, थोड़ा vitamin A डालो, सारे डालो. Then they come to you कि our drug is effective for all the indications. So that is not how the tear film dynamics work. Okay. So what my request to the pharma companies will be, rather than coming at it one solution for all the problems, you should have different solutions for different problems, right? You should have a drug, sodium hyaluronate plus something which is exclusively for NJD, which you should have something like CLC plus something which is exclusively for evaporative dry eye. You should have something which is exclusive for mucin deficiency dry eye. But somehow that part is missing in market. What we are doing, like most of us are multipurpose workers, government hospital, those who are work from Government Institute. We do research, we do patient care, we do admin, we do everything. So lubricant are also trying to do the same thing. They want to control inflammation, they want to support tear film, they want to support epithelium, which is practically impossible. Body doesn't work like that, right? If you add 5 drugs, they will interact and none of them will work. If you add only one thing, that is going to work. So this problem is rightly highlighted by Sir, but Unfortunately, the current market works like this only. They put everything into work formulation and then they want to sell it to you that see this is the magic draw that they use for all the activation, which is not possible.
What is the longest duration that content is difficult?
Liberty grass. Yes, if you, I think all of you should go through the Opus trial. At least chat GPT में जाके just write down कि give me summary of Opus trial. So you will know lymphatic grass, the symptomatic relief comes by 2 to 3 weeks, right? But if you want to have some visible effect on ocular surface, you have to continue for at least 84 weeks. So when you are starting the lymphatic grass, explain to the patient this drug is not going to work in 2 to 3 weeks. It is going to come, it is going to benefit you, but if you continue, it's for a long time. And in one trial, they found 2-line improvement in visual acuity when they continued for 1024 weeks. Okay, so you have to continue. It has to be a long-term treatment, and as you continue the therapy more and more, the improvement starts more and more, the benefit starts more and more, because T cell activation, as I said, the moment you use Lipidia, is not going to prevent 100% 80%. It will block 50, maybe then 60, then 70, then 80. It's a gradual process. So it has to be long-term use if you want to get advantage on ocular surface damage. Symptomatic relief, 2 to 3 weeks the effect comes.
So 84 weeks.
84 weeks, the trial. Sorry, 84 days, I think. Right? 84 days, sorry. My
I
bad.
think we
84 days and 1 is 2 for days.
We take the discussion after the next talk.